The clock has officially struck, oh, now you can really hear me, 9:30. So I think we'll go ahead and get started here. I see that there's some housekeeping items that they want me to read off here, so welcome to the course. Before we begin, please silence all electronic devices. Ensure you've scanned in using the QR code in order to receive credit. And we very much appreciate your feedback. Please complete the course evaluation on the event platform or in the CAP 24 app. So thank you all very much for joining. I'm Andrea Barbieri, and this is my colleague, Dr. Su-Chan Zhang. And the title of our session today is Hiding in Plain Sight, GI Infections with Minimal Histologic Findings. And to present to you what we'll go over today, we're going to introduce some general considerations related to infections of the GI tract. We'll think a little bit about our role as the surgical pathologist, and what we really aim to do is provide a scaffold and some foundation for you to consider these infections as you encounter these in your practice. This will be of assistance to you as you try to classify these using various patterns and compartments. And we'll do this all through the lens of considering cases with subtle or minimal histologic changes and those that may not even be immediately recognized as abnormal, or the part of the change that clinches the diagnosis as being infectious is subtle and may not be immediately recognizable. And the way we'll accomplish this is I will take the first introductory half of the lecture that also includes surface involvement from upper to lower, and then Dr. Zhang will go on to discuss those that are stromal invasive infections from upper to lower, and he will take us home with some summary and closing. And so to start out with the big picture here, diarrhea is a really important cause of morbidity and mortality worldwide. You can get a sense of just how the impact in 2019, it was the 7th leading cause of death, and this is really overrepresented as a cause of childhood mortality as well. And these are largely going to be the result of infections that involve the GI tract and are therefore due to contaminated food and water sources. And as you can appreciate here on the heat map, areas of the world that are disproportionately affected by lower socioeconomic status, poorer nutritional status, difficulty accessing clean drinking water, really have much higher rates of these infections. And when you think about what organisms are really causing this impact, you can see the majority of them are going to be viruses. In particular, rotavirus is a big cause, but you can see adenovirus, norovirus also on the list there. But bacterial organisms are also here with Shigella. And parasitic organisms like Cryptosporidium are also seen, in addition to a number of unidentified or unclassified organisms. But certainly, infections of the GI tract don't only cause morbidity and mortality through causing diarrhea. Through various mechanisms, viruses, bacteria, fungi, and parasites can all cause neoplasia through various mechanisms. And so we know that well, like H. pylori, for example. This is still a really prevalent disease in the world at about 40%, although it's been decreasing in recent decades. It's a really important cause of peptic ulcer disease, but of course we all know that it is associated with gastric adenocarcinoma and low-grade B-cell malt gastric lymphoma. And so when we think about our role as the surgical pathologist, these diagnoses are really often made independent of us in a number of situations. And that's because there's really robust laboratory testing mechanisms by which our colleagues can assess for these. Those include stool examination with microscopy, multiplex PCR, culture, immunoassay, and serology. But certainly there are limitations to these studies that are important to be aware of. Things like multiplex PCR might detect something that's not always clinically relevant in patients often with chronic diseases or chronic diarrhea, for example. And things like culture and microscopic examination are well known not to be terribly sensitive, and therefore we come into the fore as the surgical pathologist in diagnosing diseases often when there's an element of diagnostic uncertainty, when they're not previously considered or unexpected. Perhaps the disease is quite severe and in a vulnerable patient, or maybe the diagnosis is really just not amenable to culture or other means of diagnosis. And so we also have to be quite aware of the laboratory testing to also recommend to our colleagues if the diagnosis perhaps hasn't been considered, in addition to thinking about what ancillary testings we do on our formalin fixed and paraffin embedded tissue. And when we think about the pattern of inflammation that we can see generated by these infections that involve the GI tract, you can see there's a wide breadth of inflammatory patterns that involve the colorectum and small intestine. So you can appreciate here on the left side, these can range all the way from minimal or no inflammatory changes for something like intestinal spirochetosis or giardia or adenovirus, in addition to a number of other organisms, all the way to things that are really striking and jump out at you, like eosinophil-rich inflammatory infiltrate. So those that are obviously showing minimal or no inflammatory changes are easy to miss in a busy practice, and we'll look at a few of those examples today. But those that really jump out at you, like the eosinophil-rich infiltrate, while that's a really striking pattern, the actual finding that clinches the diagnosis, for example, a strongyloides larva, might be really focal and also kind of subtle. And when we think about infections that involve the esophagus and stomach, certainly there are kind of a more limited number of infections, and the overall breadth of inflammatory patterns is also more limited and narrow. But similarly, you can see that normal or near normal mucosa can still be present in the setting of Candida esophagitis and things like Helicobacter pylori. And more classically, we associate active chronic inflammation, for example, with Helicobacter pylori gastritis, but this can also be missed in some settings when the organisms are focal. And certainly in our practices, a challenge to making these diagnoses is the fact that there are many non-infectious mimics that overlap with these inflammatory patterns, and some of those are actually much more common than the infectious diagnosis. And so a nice example of this is in our practices here in the United States, inflammatory bowel disease is really the most common link we make to chronic colitis type pattern. However, we know more recently that lymphogranuloma venereum and syphilis can also produce this pattern of injury, and if you diagnose it as such, if you don't diagnose it as such, you can cause a morbidity in the patient. And as we think, in addition to the infectious patterns and the inflammatory patterns that I've shown you, you can think about overlaying the pathogenesis and the phenotype of these organisms and how they produce disease as also informing how we evaluate them and where we're looking for organisms. And so we call this the compartment approach. And so there are those organisms that have preformed toxins and colonization with release of toxins that you can see here. And so you might not see these organisms, but there are those that adhere to the epithelium or epithelium invasive, and you can see the scope of those infections here. But then there are also those that are stromal invasive and may produce some of the patterns that I've shown you in terms of on the infectious tables already and the inflammatory patterns. And a really good example of this that is stromal invasion is CMV, can invade endothelial cells and create an ischemic type pattern of injury, but can also invade fibroblasts and create a really robust inflammatory infiltrate that produces an ulcer. And so it can actually create a number of different patterns. But this really helps us understand where we should be looking for these organisms. And so with that introductory information, we're going to go ahead and go through a number of cases, and we'll spend some time starting out with infections involving the surface epithelium of the upper GI tract. And so case one is a 65-year-old man with abdominal pain, and this is a mid-esophageal biopsy. This is probably like a case we all get every day in our practice. You can see at low power there's really no inflammation to speak of in this stratified squamous mucosa, but there's just this really subtle focus of parakeratosis and some detached keratin debris that's piling up here. And this actually warrants further consideration in this case. And when you do look at this at higher power, you can appreciate these classic pseudohyphae and yeast forms within this keratin debris that's characteristic of Candida esophagitis. But you'll also note here that there is really no neutrophilic inflammation. And so this is sort of a potential pitfall if you're really hunting for that. Certainly, you don't need to do a PAS stain to confirm this diagnosis because it's quite characteristic on the morphology here, but you can do that and it will nicely highlight your yeast and pseudohyphal forms. Some authors have reported that NKX 3.1 is also a stain that cross-reacts with these organisms. We don't use this commonly, but it's worth noting that this could potentially be of use. And so this is an example of Candida esophagitis, which of course is the most common infectious esophagitis that we see. It's usually due to C. albicans. And the case we just looked at really exemplifies a challenge to making this diagnosis, which is a third of the cases really lack neutrophilic inflammation. And there's a number of other challenges that are really relevant for us. So they may not be suspected endoscopically in over half of cases. There are about 40% of patients who display no esophageal symptoms that we classically think of being associated with this, and half really lack any predisposing conditions that you might associate with this, such as immunosuppression, concurrent cancer, or diabetes. And so these are all challenges if you're relying on these. But the case we just looked at also exemplifies a helpful clue that us and others have noted is that desquamated epithelial cells, parakeratosis, and keratin debris is the most sensitive feature actually for detecting these Candida infections. And so always be on the lookout for that. So now armed with this new information, let's take a look at case 2. So this is a 52-year-old woman with adynophagia and heartburn, and in this case you get some EGD findings with patchy white plaques. So certainly with the patchy white plaques, we're already kind of thinking about Candida, but in addition to that, at low power, you notice that this is a much busier squamous esophageal mucosa with elongation of the vascular papillae. There's a lot more blue, the sense that there's inflammation here, even at low power. And also at low power, you get a hint even of parakeratosis down on this lower fragment and some detached keratin debris associated with the epithelial surface. And so we're really thinking about Candida in this case. But maybe surprisingly, you look at higher power and the predominant pattern of inflammation you see here is actually lymphocytic. So lots of lymphocytes percolating through the mucosa with some spongiosis between the cells, but really not much neutrophilic inflammation. But because we know that there's a high suspicion of Candida in this case, we're still hunting. And you can find these focal areas of neutrophils, so actually just a few on the surface here, and that's really all there was in this case, maybe an eosinophil here, but again, predominantly lymphocytic. And in these detached keratinocytes, you can see also these bacterial organisms that are closely associated with them, but you cannot find the classic hyphae as we saw in the last case, until you get to actually just one single level. So this is one level, and then the very next level you put down, and kind of amazingly, there's this structure, which is quite suspicious for a pseudohyphae. So all of this searching paid off. And when you put on your DPAS stain, which you would do probably to confirm this when you see it, but also if you didn't see the hyphae, you can see that it does highlight these very focal pseudohyphae. So this is a really subtle case where focal pseudohyphae were present, and this is a little bit unusual in that the patient happened to be a Crohn's disease patient who was on Remicade for 10 years. They did end up treating her with fluconazole, and her adynophagia actually resolved. So I think this is a relevant diagnosis in this particular patient, but I can't exclude that there was something else going on here in terms of the robust inflammation. So again, to emphasize, Candida esophagitis is the most infectious, most common infectious esophagitis. What we saw in this previous case is that it can induce a really robust lymphocytic inflammatory reaction, where that's actually the predominant pattern. The organisms can indeed be quite focal, and histologic clues that should always keep us thinking about this are bacterial surface colonization, desquamated epithelial cells, keratin and parakeratosis, and really the presence of any neutrophilic inflammation. And if you don't find pseudohyphae in that setting, you should apply a DPAS stain. But in addition to that, performing a PAS stain, if there's any clinical or endoscopic suspicion, is warranted. And so knowing that now and looking at another case, this is a 65-year-old man with a history of dysphagia, and the EGD in this case showed mucosal thickening and sloughing. And now, we're all thinking about detached keratin all the time, so here's tons of it, right? Lots of detached keratin debris in this case that has us thinking about Candida. And if we look at one of these pieces at higher power, in particular, there's just two areas that maybe we could hone in on to see a little bit closer. You can see that there's just some fibrin here and maybe the slightest hint of inflammatory cells, but otherwise there's really not much in the way of neutrophilic inflammation. And that more basophilic area, when you look at high power, you see something a bit unexpected. So not seeing Candida in the detached keratin debris, but now we're seeing actually a characteristic nuclear inclusion of herpes simplex virus. So this is a glassy intranuclear inclusion with peripheral chromatin margination and multinucleation. That's classic for this diagnosis. So this is to exemplify that while quite sensitive for a diagnosis of Candida esophagitis, desquamated epithelial cells is not very specific. And so this is a subtle presentation of herpes simplex virus. And you can confirm that using your immunohistochemical stain here. And certainly I think we all know that far more commonly is this really robust neutrophilic inflammation. And this is a good reminder that looking at detached material is often where you'll find the intranuclear inclusions within the squamous cells. And you can appreciate those here. This one, again, happens to be with much more neutrophilic inflammation. And one of the histologic clues when there is inflammation, which is the more common pattern, is actually seeing these little balls of necrotic keratinocytes and neutrophils that almost create these microabscesses within the mucosa. All right, case 4, so moving on to the stomach. So these are actually two different patients, and this is going to exemplify a challenge in making this particular diagnosis. So you get very generic history, very common, right? So 40-year-old woman with a history of abdominal pain. So let's look at patient 1 first. So patient 1, you have 2 fragments of gastric mucosa, and at low power you can see that this is antrum and this is body. And the antrum really shows a very mild chronic gastritis, and the body doesn't really show too much that pops out in terms of chronic gastritis. So pretty mild. And then in patient 2 with similar history, you see these are both fragments of body and fundus mucosa, and really shows no neutrophilic, chronic inflammation or neutrophilic inflammation at all, even at low power. That jumps out at you. But this is these are 2 cases that exemplify some of the challenges we face in making a diagnosis of H. pylori. So actually in both of these cases, if you go higher power, you can appreciate the classic appearance of these comma-shaped, about 4-micron H. pylori organisms that are loosely associated with the epithelial surface and floating out into the mucin, and they're abundant in both these cases. And so some of the challenges to making this diagnosis then, I showed you in patient 1 in that case, that's a really mild chronic gastritis. And so what is really the lower limit of mild chronic gastritis when you should be suspicious of H. pylori? So that one is a nice example of how it could be easily missed. And sampling in patient 2 that exemplifies the patchy distribution of inflammation we can sometimes encounter, exemplifies another challenge. But there are a number of others. So the use of proton pump inhibitors, prior or current use of antibiotics for other indications, partial treatment, mucosa with intestinal metaplasia or biopsy near an ulcer can all potentially affect if we're able to see H. pylori organisms or modify the morphology of them. And certainly when we are suspicious of this, we can always let our colleagues know that other testing methods, such as stool antigen test or urea breath test, are quite helpful as an adjunct to the diagnosis when we're struggling. So let's look at another case then. This is case 5. This is an 89-year-old woman who was admitted for a fall with a rib fracture that was complicated by pneumonia, and she developed a GI bleed while hospitalized, and therefore she underwent this biopsy. And so certainly this is the kind of case that comes on your desk and it just screams, I'm H. pylori, right? There's lots of chronic inflammation here in this antral fragment. You have superficial chronic inflammation in this body and fundus fragment, and there's probably active inflammation too in here, but nonetheless, you're really expecting to find H. pylori. But you hunt for them, you don't find them. So you put on your immunostain. And this is what you get. And you're a little surprised, but you're persistent, and you notice this focus here, which shows some focal staining, which is intracellular in location and coccoid in morphology. And so this exemplifies a different challenge in making the diagnosis of H. pylori. So the history in this patient was particularly helpful because she was hospitalized and had pneumonia, so it turns out she was on broad-spectrum antibiotics like vancomycin, zosyn, unicin, and on a proton pump inhibitor. And so this did something to this particular infection, which is modified the overall appearance of it in this way that we know they can be intracellular in location as well as coccoid when partially treated. And sometimes here you can see them admixed with the more classic morphology, this sort of comma sinusoidal shaped, in addition to the more coccoid morphology, which can be quite focal, as was noted in that case. In addition, when H. pylori is partially treated or is in unfavorable conditions like with PPIs or antibiotic therapy, you can see marked reduction in the number of organisms. As you can see here in the gastric pits, they're sort of stuck down in the pits and not on the surface so much where you would be expecting them. All right, so let's look at some more gastric pathology then. This is case 6. This is a 21-year-old man with abdominal pain, nausea, and vomiting. And here again, you can see this kind of mild chronic gastritis that you're sort of thinking, maybe it's nonspecific, but it could be H. pylori, sort of the lower limit. And notably, you only have antral mucosa here. You don't have your body and fundus. But because of the mild chronic gastritis, you do look at higher power. And when you do that, you notice there are actually a lot of organisms loosely associated with the surface here, but in a patchy distribution, and sometimes not in all the foci. You can see them here. Again, more loosely associated with the surface and out in the mucin. And they have this characteristic long and corkscrew morphology, quite a bit longer than classic H. pylori, but you do your H. pylori stain, and it does highlight these organisms. You also do a silver stain, also shows the really nice elongated and corkscrew morphology, about 9 microns long these are, and so this is a really nice example of non-pylori Helicobacter gastritis. This is an uncommon infection, certainly much less common than Helicobacter pylori, and is more prevalent in children. We use this bucket of Helicobacter helmanii-like organisms to encompass a number of different organisms that have been identified and kind of included within this group as causing this gastritis, which happens to be quite prevalent in cats, dogs, and pigs, and so it's thought that this has some zoonotic potential. And there are some challenges to making this diagnosis. As we saw, there's relatively less inflammation in the case I showed you, and less ulcer and erosion than what you might see in classic H. pylori infection, although the infections can be mixed at times and show some variation. The classic morphology is longer and more tightly coiled than H. pylori, and you can even see on the immunostain this kind of knobby end that some authors, this kind of knob on the end that some authors have described. And it's not, if you make the diagnosis of H. pylori in this case, they do actually have the same treatment. Similarly, they are associated with gastric cancer and lymphoma. But it might be a possible explanation of why a patient has a negative serology and stool antigen test, but is urease positive. And so just to look at a little bit more closely some of the challenges to making this diagnosis, on the bookends here, this is antral mucosa on one end and antral on another, and so you can see just how patchy even the chronic inflammation is in this case, even within the antrum, so it tends to be quite patchy. And then there's really not a lot of chronic inflammation at all here in the body and fundus mucosa. Just to give you a higher power view of this antrum, you can see there's actually not a lot of neutrophilic inflammation, and that's fairly typical of Helicobacter pneumoniae or non-pylori Helicobacter gastritis. And so then when we compare this to H. pylori, some of the features that we note are that the organisms tend to be fewer. They're more detached from the surface and floating within the mucin, so you might not see them as closely associated with the surface. More often, they're going to be confined to the antrum and not within the body and fundus, less neutrophilic inflammation, more patchy, and more often create this mild chronic inflammation, and so therefore could be a little bit more subtle. All right, moving on to case 7, and we're going to get into some small intestine now. This is a 38-year-old man with a history of diarrhea, and this is like, busy everyday practice, right? This is the power. You're looking at this and you say, this is normal. This is your terminal ileum. The villi look great. There's really no erosion, ulceration, but you're feeling very generous, right? So you go to medium power here. Confirms your impression, villi look good, no architectural distortion, no mucin depletion, no erosion, nothing active going on. Even more generous, you look at a different high power field. So, you convince yourself that this is totally normal, and that's a completely reasonable interpretation. You go on to the next part. And you pick up the duodenum. And the duodenum, while it has normal villus architecture, there's sort of this subtle increase in chronic inflammation here. But again, the villi look pretty normal in terms of height and length. But you do notice there's these loosely associated organisms with the surface here that are important to look at higher power. And when you do, you see the characteristic organisms of Giardia lamblia, creating this pear or teardrop shape in some cut sections, and you can see the sucking discs here. These are about 20 microns. You can use a red blood cell to help with the size. And these banana or spoon-shaped organisms, when they're cut in the alternate plane. And you can see that they're loosely associated with the surface here and floating in the negative space. So this is classic for Giardia lamblia, which is one of the most important and relevant human parasitic diseases as a cause of diarrhea. It has a worldwide distribution, and it's more disproportionately seen in areas of poverty, seen within children and adults pretty equally, and has some seasonality to it with summer and early fall. Notably, most of these patients are going to be asymptomatic, and the disease is really self-limited the vast majority of the time, but some patients go on to have chronic infections, and they may actually suffer sequelae from this. You may see this as a sporadic or outbreaks in institutional settings associated with travel or drinking water from untreated sources, and it's even been associated with sexual activity. So what we all know is that these are most common in the proximal small bowel, but more rarely they can be seen in the terminal ileum, colon, and stomach. And the preferred way of making this diagnosis, if it's thought about before it comes to us, is actually on a stool direct fluorescent antibody test or an enzyme immunoassay, which are quite good at making this diagnosis. And so the case we just looked at really exhibits something about this disease, which is that it's easy to overlook and not always where expected. And so Oberhuber et al. In 1997 published this series of cases where what we know to be true, which is that they're most commonly seen in the duodenum, but the second most common location was the ileum. And actually, when it's seen in the ileum, it's most often seen alone involving the ileum. They noted in their series that in greater than 95% of cases, the duodenum was actually normal and didn't show any inflammatory changes. This is somewhat different from what Shen et al. Saw described in 2021, where they looked at 8 patients with a positive stool-based assay and a paired small bowel biopsy and noted that the cases were actually missed. The diagnosis was missed on 50% of these biopsies. And when they really scrutinized these, they noticed that the organisms were there in retrospect, and there were some inflammatory changes present in all of those cases. One of the other interesting things that's been reported by Oberhuber et al. In 2016 is a series of 11 patients that had duodenal inflammation, but no trophozoates present in the duodenum. They were only actually present in the corresponding ileal biopsies, but the duodenum showed an abundance of inflammation, and so they discussed this as being a potential pitfall for interpretation of celiac disease, which is probably one of the things we're all looking at more commonly. So just to go back to this case then of this terminal ileum, we know that we have giardia in the duodenum, but let's look a little bit more closely here at this totally normal duodenum. And in fact, you can find just a few trophozoates classic for giardia in here. And there are some mimics in terms of detached mucin that can look a little bit like giardia. Some authors have published that c-Kit immunohistochemistry can stain these organisms. We don't use this too much in our practice. This is what the stain looks like in our lab. I understand it's quite variable in labs, but this could be helpful or useful potentially in some situations if you wanted to try. All right, case 8. So another example of a small intestinal biopsy here. This is a 10-year-old male with a history of Down syndrome, renal transplant, and watery diarrhea. So certainly this piques our interest for infection a little bit more. But when you're looking at low power, the villi look reasonable. Maybe there's some tangential sectioning. But what jumps out a little bit is there's some mucin depletion and even the sense of some epithelial disarray where the nuclei are not quite aligned and they're looking a little more disorganized. So looking at this more closely, you can actually see that there is some epithelial disarray, mucin depletion, and actually the other thing that you can appreciate is there's a decrease in goblet cells, which is another feature of chronic injury. And you can appreciate a number of organisms here that are these classic blue beads, as they've been described, ranging from 2 to 5 microns in size, loosely associated with the surface, but also within the epithelium. That's quite characteristic of Cryptosporidium parvum. And you can see that even more in this focus here. There's more epithelial injury and mucin depletion, and the organisms are more abundant in this focus. Giemsa stain is quite helpful for staining these organisms. And so Cryptosporidium parvum is actually one of the most common human coccidian intestinal parasites, is the most common human coccidian intestinal parasite. And it's the leading cause of outbreaks of diarrhea linked to water. And this is endemic worldwide, which differs a little bit from its counterparts. So it's been associated actually with outbreaks in recreational pools and food and on surfaces as well. And kind of like giardia, these patients can range from being asymptomatic to having severe chronic diarrhea with sequelae. Patients with immunocompromise are disproportionately affected. Travelers and young children are also populations that are more affected. And while it looks adherent to the surface, it actually does invade the epithelium and sits in a parasitiferous vacuole within the cytoplasm. And the Giemsa stain, as you saw, can be helpful here in addition to Gram stain in highlighting those organisms for you. And stool DFA is a helpful tool in making this diagnosis, as is multiplex PCR, which is increasingly utilized for this purpose. And to differentiate these, some of the other organisms that may come up in the differential diagnosis are the other coccidians, which are less common, and they have a little bit of a different distribution in terms of where they're endemic. So where Cryptosporidium is endemic worldwide, Cyclospora and Cystoisospora are actually endemic in tropical and subtropical regions. And so Cyclospora, you can see this example here, classically sits in this supranuclear vacuole and is about 2 times the size of Cryptosporidium parvum. And it's classically, it's been reported as having outbreaks associated with imported and domestic produce, and is actually increasing in the United States at a rate which has now prompted more recently the CDC and the FDA to create a task force to examine this and help manage this. But imported produce like cilantro and raspberries is where it's been reported. And Cystoisospora is actually a little bit larger. It's the largest coccidian and it's the least common, but you see it more in travelers returning from endemic areas, and it sits characteristically in this subnuclear vacuole that you can appreciate here, sometimes where it pushes up the nucleus to almost create like a T-shape appearance. And the organism can also be seen within the histiocytes of the lamina propria, where it tends to then induce more of an eosinophilic inflammatory infiltrate, and the patients may also then have peripheral eosinophilia, which can be a helpful clue to the diagnosis. All right. So let's move on to infections that involve the surface of the lower GI tract. So case number 9, this is a 47-year-old man with abdominal pain and a change in bowel movements. And you can appreciate the colonic mucosa here, shows patchy inflammatory changes. This one is more normal in appearance. But here you see that there's an erosion with some chronic inflammatory infiltrate as well. And even maybe this hint of bridging of the crypts here. And when you look, you notice that there's actually quite a bit of detached debris. You could even see it a little bit at low power, and it's associated with some of these foci that are actually are more near normal as opposed to that eroded area. And when you start to look more closely at these, this is something that can be rather tricky, but is important, of course, for us to catch. This is an example of Entamoeba histolytica colitis. And these organisms are often embedded in this detached fibrinous debris along the surface. And you can see they're about 20 microns in size. They characteristically have this round, eccentrically located nucleus with a prominent central karyosome. And kind of this appearance of uniform peripheral chromatin margination around the nucleus with this somewhat gray vacuolated cytoplasm. So this is all important because it helps us distinguish it from macrophages, which I think is the easy thing to mistake these for in a busy day. And certainly you can highlight macrophages with CD68, which can be helpful here because it will not highlight your Entamoeba histolytica. And you can see that the red blood cells here are also ingested, which is characteristic of Entamoeba histolytica in particular versus some of the other amoeba that one might consider. So again, this theme, a little bit of the detached material is always important to look at. All right, case 10. So this is a 55-year-old man with a polyp on screening colonoscopy, and this isn't even terribly impressive for a polyp. This actually came through as a consult case, and it was associated with a more relevant diagnosis in another part that the patient was being seen at our institution for. And they had sent all the parts, and we were looking at this and not terribly impressed with a polyp. I think it was called maybe an early hyperplastic polyp, which may be a fine description. But as we looked at it, we noted that something was not quite right, even at low power here. But super easy to say that this is normal and move on to the next case if you're busy. But at low power, you can appreciate that there's just this subtle accentuation of the surface epithelium that looks a little bit more basophilic. And when you do look at higher power here, you can appreciate this fringy brush border that's characteristic of intestinal spirochetosis. And retrospective reviews of a large cohort suggest that many of these cases are actually missed due to absent or minimal inflammatory changes, as we're noting in this prior case. But you can see the organisms tend to associate with the surface and only go partially down into the colonic crypt. They might not go down too far at all, in fact, and so can look a little bit different depending on the foci in the case. So this is then an example of intestinal spirochetosis, which is due to Brachyspira alborgii and Pilosa coli. This has a global distribution with some variability, and in particular, it's more common in rural and developing areas and is also reported more frequently in men who identify as gay. Most often, this is going to be incidental and asymptomatic. It may be seen in a polyp, and some authors have reported rectal sparing, which may or may not be present. Some have also reported that when you are evaluating for this, you can potentially note some mild inflammatory changes, like a mild increase in eosinophils with subepithelial clusters or some lymphoid follicles as well, but they may not always be there. And there are no clear guidelines on who needs treatment, and we know that some of these cases will actually resolve spontaneously. This highlights a really nice Treponema pallidum stain, which highlights these organisms. They actually, Treponema pallidum immunostain cross-reacts with the Brachyspira organisms, and this has been reported to be the preferred stain for its ease of interpretation, which is nicely seen in this image, and also reduced technical time. And so we often use this in our practice to highlight these more often than the silver stain, actually. And so I did mention, that many of these patients resolve spontaneously or asymptomatic, and so what's really the clinical significance to this diagnosis? So we do know that a subset of patients will have diarrhea, abdominal pain, or alternating bowel habits, and actually about 50% of them describe symptom improvement when they are treated with metronidazole when we make this diagnosis. So this actually will help a subset of patients. And it kind of begs the question of what really is this disease? Or organism? Is this a pathogen, or is this a commensal organism? And so just to note, out of curiosity, folks have noted on electron microscopy studies that there is invasion of the epithelium and destruction of the microvilli that has been noted. And actually on whole genome studies, there also has been shown to be potential for host microbe interaction through enzymes like sialidases, collagenases, and efflux pump antibiotic resistant mechanisms. And these are things that are all present in other GI infections, so it just makes one think. The other kind of interesting thing about this is that it's diagnosed in 20 to 40% of patients who have irritable bowel syndrome in more recent studies. And this slide here highlights a Treponema pallidum stain, and just to show kind of an interesting finding that we've noticed in our practice and others have noted when evaluating intestinal spirochetosis, you can actually sometimes see the organisms invading the underlying lamina propria, and this shouldn't dissuade you from making a diagnosis of intestinal spirochetosis or make you think that this is something else like syphilis, for example. And we've noted this doesn't seem to have any association with symptoms and is more just a curiosity that you might encounter in your practice. And I think with that, I will turn it over to Dr. Zhang for the second part of this.
Good morning, everyone. Yeah, thank you for attending our session. So continue from Dr. Barry, I will talk about GI infections involving lamina propria and or submucosa, and without significant pathological changes. So we will not talk about the GI infections with obvious pathological changes, just also subtle changes. Can give you some hint how do we work up for these infections. So Dr. Barbara showed this table before, every single site of the GI tract, they have different infections. Every single infection, they can have different inflammatory pattern. So they can be, if neutrophil predominant, can be eosinophil predominant, can be histiocytic, also can be lymphoplasmacytic predominant. Sometimes I may not see any morphology changes suggest infection. So I will work up this one by one, to show you some cases. How do we work up for these cases? So first, start with the near normal to minimal changes, when there is lamina propria or submucosal involvement with GI infections. So when we receive these kind of specimens, when we look at the slides, we always ask ourselves, why the patient come here for the biopsy? And if the patient is immunosuppressed or not? And what's the findings for endoscopy at that time? And when you see the slide, you do not see anything specifically. You always need to go to higher power to identify any subtle changes, any inflammatory changes may suggest some infection. For example, this is case one. This is a 56-year-old man with HIV and on heart therapy. And the patient came for indication is abdominal pain and then weakness. And endoscopically, they do not see anything. You can see here the normal esophagus have superior gastric mucosa. So when we review the gastric biopsy here, it's not that impressive, but we do see reactive gastroscopy. And if you go to higher power, still reactive gastroscopy, you may see some cluster of inflammatory cells. That's pretty common in every single biopsy, right? But if you go to even higher power, you can recognize something. You can see my arrow here, there's a small vessel here, capillary, and one of the capillary endothelial cells is enlarged. And this is another small capillary endothelial cells enlarged. And also you can see some stroma fibroblasts also enlarged. They are large cytoplasm. But the morphology is not that typical for CMV infection. But remember that the CMV infection, they often infect endothelial cells. So you can see the immunostain for CMV. Very impressive, a lot of cells. Even though we can see one epithelial cells are infected, but both of them are stroma cells and endothelial cells. The similar case for case two. This is a 54-year-old woman and a patient with history of kidney transplant, and also presented with nausea, vomiting, abdominal pain. And this is indication for biopsy. And endoscopically, essentially normal. You can see here, esophagus, stomach, duodenal are normal. So this is a representative section from the gastric body. You can see the oxyntic mucosa. We do not see obvious inflammation, but we do see here some calcification in this area. They're very common for patients with renal failure. You can see calcinosis. Low power, I looked carefully. I saw some cells in the epithelium a little bit larger. Then I went to higher power. So when you went to higher power, you can recognize right now some epithelial cells in the crypt area. They have a lot of cytoplasm inclusions. And then this one with a very beautiful nuclear inclusion. And then another area in the higher power, you can recognize many of the epithelial cells with cytoplasmic inclusions and the nuclear inclusion. This morphology is very typical for CMV, but we do not see obvious, very impressive inflammation. So you can see the immunostain here. Can highlight so many infected epithelial cells. Also, the CMV infection in the GI tract is not that common, but the most commonly seen in patients in immunosuppressed conditions. For example, maybe HIV patient, maybe patients, for transplant, kidney, liver, or sometimes heart, lung transplantation. You can see this patient often with, CMV infection. And also sometimes, for IBD patient, IBD patient after treatment, refractory for the treatment, they often with CMV infection. I will mention later. So the cells infected, most commonly seen is endothelial cells and the fibroblast. Rarely we can see epithelial cells. You can see our second case, most of the epithelial cells, is that not that common. And then the classic viral inclusion morphology, you can see the OI morphology. When you see it, they're very typical. But remember here for the GI tract, up to 75%, 37%, though they show atypical morphology. That's like our first case. And also, the patient I mentioned is most commonly seen in immunosuppressed patient. Since the patient is immunosuppressed, they cannot produce enough inflammatory response. That's why all these biopsies, you may not see inflammation. Inflammation very, very subtle. That's why all these patients, if you know the patient is immunosuppressed, you should pay attention, go to higher power, recognize anything suspicious, and then you should have a very low threshold to order CMV immunostim. And also mentioned for the IBD. For the IBD, we do stands for CMV. Sometimes clinicians request. In our daily practice, they ask you, okay, please do a CMV. And then for the CMV, how do we report CMV in IBD patient? And here you can see that we always give a comment. The comment is high density or low density. What it means for high density or low density. So far, there's no good cutoff. Somebody use, one biopsy, you see 5 positive CMV cells. Somebody is 10. But most of the studies, they use 5. So you can see. So why do a patient pay attention to the density for the CMV IBD patient? You can see the left panel here. So if you have a low density for CMV infection, that means one biopsy you only see less than 4 CMV positive cells. Yeah, the patient compared to you have more than 5 CMV positive cells, they have a very low rate for colectomy. And also for the treatment, also important. The clinician may not treat the patient with CMV low density. For example, you can see here, the low density, treatment without treatment, no difference for colectomy rate. But for the high density of CMV, if you treat the patient for CMV, and then they have a very low rate for colectomy. So that's the reason we report for the low density and the high density. Generally, we use the 5 at cutoff. So let's move to case 3. This is also with very subtle changes. So this patient is a 35-year-old man with history of HIV and then presented with abdominal pain and diarrhea. That's the indication. Endoscopy, they found something. You can see the endoscopy showed erythematous patches in the stomach and the sigmoid colon. You can see the stomach here. You can see a red patch here. And then this biopsy is low power. You can see low power is not that impressive, not remarkable. If you go to higher power, still not remarkable. But if you pay attention, you can see the laminar periphery, maybe some inflammatory infiltrate, maybe some spindle cells, and this area more pink, looks like some hemorrhagic changes. If you go to higher power, you can see some hemorrhagic changes. Hemorrhagic change is very common for every single GI biopsy because there's a procedure associated. But this hemorrhagic change looks like more old. You can see some hemosiderin deposition here. When you see this, and you know the patient is immunosuppressed HIV patient, don't forget about Kaposi sarcoma. And then we ordered HHV8. You can see how impressive it is. And then the same patient, sigmoid colon, they also showed red patches. And then this low power, you can see the 4 pieces of the GI biopsies. Low power is not that inflamed, is not impressive. But if you go to higher power for one of the fragments, you can see the laminar periphery more busier than normal colonic mucosa. And also you can see a lot of spaces. That means vascular channels, lots of spaces. And you see many, many spindle cells. We knew this patient with Kaposi sarcoma in the stomach. And then we also ordered HHV8 in the colon. You can see highlighted the HHV8 positive cells. That colon also involved by Kaposi sarcoma. The same as other immunosuppressed patient, Kaposi sarcoma more commonly seen in immunosuppressed patient. For example, patient may have AIDS associated, or patient with organ transplant. In this situation, the most common in US. And then we all know for Kaposi sarcoma often involves skin. But in the GI tract, if you only have GI tract Kaposi sarcoma, only about 21% patients, they involve skin. So that means near 80% of GI Kaposi sarcoma without skin involvement, only involve GI tract. And then for the GI tract, the most common locations in the stomach and the colon. That's like our case. Endoscopically, the morphology is not that typical for anything. You may see red patches. Sometimes you may see a small polyp. Sometimes you may see ulcer, you may see some bump. It's not typical. And then as a pathologist, we work for this corpus sarcoma. Sometimes we miss diagnosis. In what situations we often miss for diagnosis? So one important situation is the biopsy from esophagus. Because esophagus have squamous mucosa. We always pay attention to the squamous mucosa. If there's a fungal candida there, if you have herpes there, if ulcer there, if you have a lymphocyte, you have eosinophils. We rarely pay much attention to the submucosa. And most of the times, the biopsy, they only give you a very tiny part of the submucosa. So that's one part we often miss. The second part is the biopsy is so small. And then they have a very subtle change. We will not pay attention. And then the third situation is, you have multiple pieces, but very patchy distribution. We may also miss. And that's why, when you deal with a HIV patient, and then endoscopically they do see something, and then we see some hemorrhagic change, spinosyle change, don't forget to put one HHV immunosensor. We should use a very low threshold. What kind of morphology changes that may say, hemorrhagic change, spinosayles? We also meet with other morphology changes. This is a study from Emory. Dr. Zheng published 46 cases of GI corpus sarcoma. They divided the morphologies into 7 categories. The most common one that's in the laminar periphery, you can see the lymphangioma leg, just like this picture here. This is my case. You can see the laminar periphery. You can see a lot of dilated lymphatic channels. When you see these morphologies, think about maybe the corpus sarcoma. It's better for HIV patient. And you may see hemorrhagic changes. You can see the laminar periphery, a lot of hemorrhagic changes. Also, you can see inflammatory changes that can mimic H. pylori infection. So I can show you another case later. So sometimes in laminar periphery, you can see spinosayles can mimic inflammatory myofibroblast tumor, or sometimes can mimic GIST, or inflammatory fibroid polyp. So just remember, HIV patient, you should have a low threshold to order HHV8. So let's move to the second pattern, for the GI infection involve laminar periphery or submucosa. This one we can see eosinophils. So for the eosinophils, we know involved the GI tract can be neoplastic, for example, in the mastocytosis, Langerhans cell histiocytosis, or most of the time in our daily practice, they are non-neoplastic process. For example, it may be allergy, maybe idiopathic, maybe fungal infection, maybe parasitic infection, even IBD. It's better for IBD. We often see a lot of eosinophils, especially after treatment. But this inflammation, eosinophils, generally they are more diffuse. So let's see a case here. This is a 35-year-old man, complaint of abdominal pain and history of Crohn's colitis. But remember Crohn's colitis, and then 5 years ago. And then the patient got a follow-up. You can see the endoscopy showed the Crohn's disease score 0. So that means that the mucosa recovered, healed very well. But they do see a nodular mucosa in the descending colon. You can see some small nodules, nodular because in the descending colon. You can see the biopsy from the descending colon. All the parts of the colon biopsy totally normal. Only the descending colon here, you can see some nodules. You can see this piece totally normal. And this piece a little bit inflamed, and this piece a little bit inflamed. If you look at low power, okay, the patient with a history of Crohn's disease, this perfect fit, maybe the patchy distribution after treatment is nothing, right? But if you go to higher power for this piece, I'll give you an example. You start to see some cluster of eosinophils, and a cluster of eosinophils, and also eosinophils in the submucosa. Whenever you see this collection, localized eosinophils, so that's generally not, IBD. IBD generally, after treatment, more diffuse. So when you see this localized, think about it, maybe some fungal, maybe some parasitic infection. So, and how do we do? We do level, right? That's our daily practice with other levels. So after the level, you can see clearly in the submucosa, you can see something here, you can see marrow here, go to higher power. Now you cannot miss anything. You can see some mucosa just like a granuloma, and then this piece of eosinophils before, and then you can see the parasitic egg. Also can see the spine here. So this is schistosomiasis, right? And then I called the clinician. I told the clinician, okay, the patient with a history of Crohn's disease. So far, I do not see any features such as Crohn's disease. Maybe that's a misdiagnosis, right? And then the clinician called the patient. And the patient said, okay, I took a trip to Brazil 7 years ago. At that time, I got schistosomiasis. I got treated. And then I went back to Brazil last year. Maybe I got another infection. Okay, this is another similar case. This is a 56-year-old man from Honduras. This is an immigrant. Generally, in our daily practice, we see more and more immigrant biopsies. And then this patient presented with chronic abdominal pain and also unintentional weight loss. In this situation, the patient underwent for colonoscopy to screen if there is colon cancer or not. But the clinician did not recognize any tubular adenoma, polyps, or cancer. But they recognize, you can see the nodules in the cecum and also the ascending colon, very small nodules. So this is one of examples of the small nodules. You can see the cologic mucosa is essentially normal. But this piece here, you can see some collection of eosinophils, very localized. And the eosinophils also extend to submucosa, similar to our last case, right? And then go to higher power, still you see more prominent eosinophil collection. But we do not see any parasite, no egg. How do we do? As the last case, right? To level. Yeah, we're so lucky, you can see my arrow here. Up to level, you can see this parasite showed up. You go to higher power, you can see clearly here. In the center of the eosinophils. Yeah. So this is a strongyloides lava, right? So confirmed. Now, if we have this case in the gut level, you can see it, or you can see this biopsy. Nobody will miss it. Very easy to make a diagnosis. Okay, this strongyloides. But sometimes we're not that lucky. For example, for this case, so this 47-year-old woman with abdominal discomfort and the colonoscopy for cancer screening. The entire colon is normal. Only in the cecum, they found one white plaque, 1 millimeter small plaque, and then get biopsied. You can see the biopsy from the colon. Essentially, every single piece is normal, only one piece of the colon. And then you can see some mucosa collection or something, and go to higher power, you can see the eosinophils in the submucosa. This is a localized collection of eosinophils. And in the lamina propria, you can see some increase of eosinophils, this region. So same thing we need to do level, right? But this level, you can see after deeper levels, the eosinophil collection in the submucosa disappeared. And also we do not see anything obvious in the lamina propria. How do we do for this case? We just let it go? Generally, for these cases, you need to give a note to alert clinician what do you think. For example, this note I gave to the patient, to the clinician. I said one of the fragments of chronic mucosa in the mucosa and submucosa with collection of eosinophils. And this is more commonly seen in parasitic infection, for example, strongyloides or schistosomiasis. And then we suggest them to do a test. The clinicians sometimes they listen to us, but sometimes they do not listen. But this time the clinician listened. The test patient is strongyloides. You can see the antibody come back here as positive. It's very important to recognize this. Why it is very important to recognize this? You can see the note from the test. If this patient with indolent infection or called latent infection, and the patient is okay, wherever the patient become to immunosuppressive situation, for example, patient with organ transplant, patient with cancer get chemotherapy, at that time, the patient will develop a hyperinfection. When you have the hyperinfection, the mortality rate is very high, more than 80%. So at that time, the treatment may not be effective. So that's why we are important to recognize, to alert clinician to do the test. Okay, the eosinophils. Let's move to histiocytic predominant GI infection without significant morphology changes. So same thing as other GI biopsies, always ask yourself indication for the biopsy, immunosuppression or competent for the patient situations. And if the patient with travel history. And if you see histiocytes, and then this diffused distributed or localized, do you see any granuloma? And then if you see histiocytes, what's in the cytoplasm? Is it foamy, or do you see occlusions? Do you see granules for that? So this is the most common infection in the GI tract when you see the histiocytic infection, the infiltrate. For example, the MAI is the most common one, followed by Whipple's disease, and then histoplasmacytosis. These three more common. And then the first one, rhodococcus, is not that common. It's not that common. So I will show you two cases in this category. So this first case, case 66, 57-year-old man complained of abdominal pain and diarrhea. And then when this situation happens, the clinician always want to rule out celiac disease. And then they did the biopsy. Stomach is normal, esophagus is normal, and the duodenum looks like normal. But you can see we received 3 pieces from the duodenum. So this piece is essentially low power, essentially pretty normal. And this piece, you can see some dilated lymphatic channels, and this also essentially normal. But the first piece, you go to the essentially normal duodenal mucosa biopsy. You can see the villus height is normal, 3:5:1 ratio. We do not see any intraepithelial lymphocytes, and then we do not see any Giardia, as Dr. Barbary showed. We do not see any other parasite in the surface. But the low power is start to see in this villi. In this villus, you can see some collection of foamy histiocytes. You go to higher power, you can see small cluster of foamy histiocytes. And then go back to this piece, with dilated lymphatic channels, looks like low power. You can see dilated lymphatic channels in the laminar propria. You still can see the clusters of foamy cells. Go to higher power, more obvious. You can see small clusters, foamy histiocytes. So wherever you see morphology, you see the foamy histiocytes, clustered sheets, plus with these dilated lymphatic channels. Your first impression will be Whipple disease. And then what stain you need to do? PSD, right? So this is a PSD stain or PS stain. So you can see the foamy histiocyte contains this granular, chunky bacteria, much larger than MAI. I will show you later. And you can see the dilated lymphatic channels. And then these bacteria, they are negative for AFB stain. So confirmed this is a Whipple's disease. Now this one is more obvious. This second case, this is more obvious. You can see the laminar propria with sheets of foamy histiocyte infiltration. You can see different sizes of the dilated lymphatic channels. This is very typical for Whipple's disease. And for the Whipple's disease, remember this is a systemic disease, not only involve GI tract, especially not only involve the small bowel and the jejunum. They all involve the joint, maybe nervous system. Sometimes the patient, everything fits for Whipple disease, but all the GI biopsy is totally normal. That happens very often. And then for the GI tract involved, I mentioned small bowel is the most common location. But we do get biopsies often from the duodenum, because the jejunum is the most common location, but very hard to get the biopsy from jejunum. And then morphologically, the foamy histiocytes often mimic MAI infection, because both of the bacteria are positive for PSD stain. But in the bacteria for MAI, positive for AFB, this one is negative for AFB. And the morphology will be different. I can show you another case later. But remember, for the Whipple disease, sometimes the foamy histiocytes very subtle, only 2 or 3 they are there. Sometimes they're only located in submucosa. So when you look at these cases, do not only look at the laminar propria, also pay attention to submucosa. And if you do the stains, you do not see anything, do not forget, such as a clinician, we may have other modalities can make a diagnosis. For example, for PCR, if you have no PCR in-house, you can send to CDC, they can do that for you. Also, you can do electron microscopy. So that's not commonly used, right? Most of the labs do not have EM so far. Although they can do immunostaining. I think many of the labs, you do not have the antibody to do immunostaining. Just remember, all these ones you can send for all the tests. Okay, since I mentioned the main differential is MAI infection, I have to show you another case. So this is a 37-year-old man complained of fever, fatigue, and abdominal pain and diarrhea. And then the endoscopy showed, see the duodenum here. And then do see this skeletal mucosa. When you hear about the skeletal mucosa, always think about the celiac disease. And then the clinician asked us to rule out celiac disease and the possible infectious etiology. And then this is the biopsy we received. You can see the red part is totally normal, right? The villus accusator is normal, but in the left part of this biopsy, you can see localized collection of some cells in the laminar propria. If you go to higher power, you can see all the laminar propria infiltrated with these foamy histiocytes. If you go to higher power, you can see all of them. But this one, you do not see the lymphatic channel dilatation, right? Different from the Whipple disease. So the main differential so far is MAI or Whipple disease, right? Yeah, for this one, we did PSD stain and also AMB stain. You can see the PSD stain highlight all the histiocytes, and the AMB stain also positive. And this bacterial morphology is different from Whipple disease. So Whipple disease, I mentioned, is more chunky, more granular. This one more delicate, more filamentous, more thinner, more narrower. So the morphology is different. So if you don't have the PS stain, you still can say this MAI, this is not Whipple's disease. The morphology is different. And then for this one, for MAI, sometimes can be very prominent. They can cause, the entire small bowel infiltrate with this, and they cause stricture, obstruction, can mimic malignancy. This is a resection case. You can see the small bowel, all the lamina propria infiltrated with these foamy histiocytes. And then this MAI infection involved the small bowel, cause obstruction, and they get resected. So MAI is the most common mycobacteria isolated from the GI tract, same as other infections, both commonly seen in patients in immunosuppressed situation. For example, HIV or organ transplant, for that one. And endoscopically, generally, sometimes totally normal. I can show you a case, endoscopically totally normal, but you can see the infection. Sometimes you may see some small nodules, some bump, some stricture, some erosion, some ulceration. Sometimes they can form, some mass lesion, can mimic malignancy, but not that common. Morphologically also different. If the patient is immunosuppressed, you can see the sheath infiltrate of the foamy histiocytes. But if the patient is immunocompetent, you can see granuloma. So all the patients, generally we encounter in our daily practice, they are almost immunosuppressed. That's why we do not see granuloma. Most of us see that sheath of the foamy histiocyte infiltration, and then they continue the bacteria. And then the stains we use in the AFB is positive, PSD, PS, all positive. But remember, you can do GMS. GMS is a very good stain for fungal, right? But this also stains for the mycobacteria, but the morphology is different. This one more thinner, more delicate. Fungal always larger. So you can see the morphology different. Okay, since we're talking about the histiocytic infiltration and the localized, this is another case I want to show you. This patient, a 60-year-old man with diabetes and diarrhea. And the colonoscopy totally normal. And except one small, 3-millimeter polyp in the cecum. And since the patient with diarrhea, they ask us to rule out, microscopic colitis. And then this is the biopsy. You can see the entire colon biopsy totally normal. You can see the two pieces totally normal. So there's no lymphocytic colitis, no cholangiocytic colitis. So we still cannot, explain why the patient with diarrhea. Maybe, IBS, right? That's the most common one. And then this one, I do see a polyp. The polyp, you can see the lymphoid aggregate, right? That's very common in our daily practice. We see lymphoid aggregate, and endoscopically, this all polyp. We just let it go, pass, right? But if you go to higher power, you can recognize something. You can see the lymphoid aggregate. You don't see more pink cells. Generally, this one, we do not see many pink cells. If you go to even higher power, you can see the pink cells like histiocytes, and then cytoplasm more granular. And then if we pay more attention, and then start to see some cells with targetoid inclusions. So what now? And then if you want to see this one, called it Michaelis Gaussman body, right? And then the special stains will be calcium stain or iron stain. This Vancosa stain highlights all these targetoid inclusions. So this is a molecular plaque here in the colon, right? Mimic lymphoid aggregate. We often see this. And the molecular plaque here, inflammatory process related to defective macrophage response to bacterial infection. And most of them, E. coli. And that's the most common location we see in the GU tract, in the bladder. GI tract, we do see, but not that common. You can see this study, they showed, 26 cases, 23 of them from the colon. So only 2 cases from stomach and 1 from appendix. For myself, I only saw 1 gastric molecular plaque here so far. It's not that common. Most common one in the colon. And endoscopically still, the morphology is not that typical for anything. So they can see, from polyps, they can see flat lesions, ulceration, mucosal erosion. Sometimes it can be a mass forming for mimic malignancy. And pathologically, we pay attention. You do see the localized infiltration for the histiocytes, But generally, these cytoplasm more eosinophilic, more granular. And if you look carefully, you can see the targetoid lesions. Because in the targetoid lesions is laminated material, and then they contain iron and calcium. That's why we do iron stain, we do Vancosa stain to highlight that. But do we really need your daily practice? Generally, we don't need. If we see it, you can call it. But for the academic places, we show the resident, we show the trainees, we often do the stains. Sometimes we confirm ourselves, right? We do the stains. And then I mentioned in the last sentence, you can see here, sometimes maybe associated with lymphoid aggregate, can mimic lymphoid aggregate. Okay, let's do this section, lymphoplasmacytic predominantly infiltrate with minimal histologic changes. That means the minimal histologic changes to suggest infection, maybe suggest something else. Let's see this case here. So this one, for same thing as prior biopsies. When you see the inflammation, lymphoplasmacytic infiltrate, still ask the indication, and then if the patient travel history. And also because IBD patients, they often with this kind of lymphoplasmacytic infiltration, right? Is it possible the patient with IBD, and endoscopically, if the clinician think this IBD or not. And also, these infiltrations, they are localized or diffuse in the entire colon, only involve the left colon, only involve the rectum. And also, another question, if a younger patient, even the older patient, you always think about the patient with high-risk sexual behavior, if you only have the rectum involvement. So let's start with case 9. So the 40-year-old man with intermittent episode of abdominal pain and rectal bleeding. You can see the rectal mucosa, here the endoscopy they showed moderately erythematous mucosa with the stricture of the distal rectum, the stricture of the distal rectum. And the other parts of the colon is normal. And then clinical result, maybe this is a neoplastic process. Ask us to rule out possible for malignancy. This is the biopsy I received. You can see the biopsy here, almost the normal colonic mucosa, but definitely I do not see any dysplasia, no tubular adenoma, no infiltrative invasive adenocarcinoma. So that part, low power, we can exclude. No carcinoma, no malignancy. But if you go to higher power, you can see this piece looks something in the laminar propria. If you go to higher power, you can see this piece of colonic mucosa is essentially normal. But this piece here, more dense lymphoplasmacytic infiltration, and the surface with some erosion. If you go to higher power, still you can see lymphoplasmacytic infiltration and surface erosion, some crypts, you see some neutrophil infiltrate. But the gland architectural distortion is not that obvious. I do not see any panel-cell metaplasia. And think about the patient, the young patient, only the rectum involved. Always keep yourself. Is this possible? This is a sexually transmitted disease. So this one we did Treponema pallidum. You can see almost every single piece, they are negative for the stain. Only the inflamed area, if you go to higher power, you can see more clearly. So this is the syphilis. So this is syphilis proctitis, and then cause stricture of the distal rectum. And the diagnosis is very, very important because this is treatable. This is not a malignant process, not IBD. If you think this IBD, and the patient will be treated IBD, will cause even worse of the infection. Similar case 10. So 52-year-old man, a little bit older but still young, and then with rectal bleeding. And then colonoscopy showed here, fungating and ulcerated mass in the distal rectum and the circumferential. Other parts of the colon were normal. And then clinical impression based on the endoscopy, there's a malignant tumor of the distal rectum. Let's see, you can see the endoscopy finding. There's a mass lesion, ulcerated, really like a malignancy process, right? So let's see the biopsy here. So everybody can recognize if you only practice for 2 days. There's no tubular adenoma, no invasive carcinoma, not like a malignant process, right? But we do think this one totally normal, but this piece and this piece looks like a laminar propria is expanded. You may see some architectural distortion and some inflammation go to the submucosa. So let's choose this piece, go to higher power. So you can go to higher power. We do see architectural distortion, but not that obvious, not that severe. We do see lamina propria with lymphoplasma city infiltration. We do see some error like basal plasmacytosis, but really like IBD, right? But for this IBD, I do not see any panel-cell metaplasia, and then this inflammation goes deep, go to submucosa. And I do not see active colitis. So that means the cryptitis, crypt abscess, they are not obvious here. So when you see this morphology, just think about maybe this another entity. It's not IBD, but really mimic IBD. And then if you go to higher power for one of these pieces, you can see this inflammatory infiltration, lethal plasma cells, and it's essentially okay, right? But if you pay attention for the surface here, you can see some coating here. But Dr. Barber showed for the intestinal spiral keratosis, you see the higher, carpet-like, but this one, because it's very inflamed, is not that typical. And then this is another piece, the architecture is preserved, not that inflamed. If you go to higher power, you start to see the surface with some coating. Even for the glands here, the lumen surface, you start to see the coating. But this one I did not recognize before I ordered treponema stain. So I thought, this morphology is not IBD, it's not a malignant process, and possible this is a sexually transmitted disease. Possible this is syphilis. And then we ordered syphilis stain. You can syphilis stain did not show up syphilis, but highlighted the surface with spiral keratosis. But we know the stain, treponema stain, and then they overlap with intestinal spiral keratosis, right? So I recognize, this, oh my God, I missed this one by histology. So when I went back to see histology, I recognized that one I showed you before, right? This is keratosis. So Dr. Barber mentioned for the intestinal spiral keratosis, generally seen in patient, maybe IBS patient, or patient without any symptoms. To my experience, I had at least 2 cases. I called this one, it had a spiral keratosis. Later on, they identified patient with diarrhea and then identified the 2 patients who were all HIV patients. So sometimes they can be an indication index for them to think about the patient maybe even surprised, maybe HIV patient. For this one, it's not syphilis, right? But the morphology really alerted me to still think about something. Maybe it is a sexually transmitted disease. So this is the note I put in my report. You can see I realize it's a mass lesion, but I do see chronic inflammation, lymphoplasma city infiltration. I do see mild glandular arterial distortion. I do see a small ulcer, but I do not see malignancy. I did treponema stain, they are negative for syphilis, but other diseases, for example, gonorrhea and chlamydia, as a clinician to exclude them. And this time the clinician also listened to us, and then she tested the patient. You can see the bottom is the test result. And the chlamydia came back positive, gonorrhea is negative. And then the clinician was very happy at that time. She sent me a message here, thank you, the note and the call. And his rectal chlamydia test now is positive. And there have been reports, for the chlamydia infection, they can present with a rectal mass, can mimic malignancy. And then the patient was treated with doxycycline. So that's very impressive for us to remember this. This, from the CDC website, you can see here the 3 most common STDs, sexually transmitted infections, gonorrhea, chlamydia, and syphilis. Especially for syphilis, from 2018 to 2022, within the 5 years, you can see this about 80% increase within 5 years. So that means in our daily practice, we should pay more and more attention. If you only have a biopsy involving the rectum, do not forget syphilis or other STD. So what kind of features can alert you? For example, if you only get a biopsy, involve the rectum, other parts is normal. Do not call it ulcerative proctitis immediately. Think about other morphology, other etiologies. And also you can see lymphoplasma city infiltration can be very dense, but generally the morphology, the architectural distortion not that obvious. You do not see pancell manipulation. Generally you do not see eosinophils. And also, for the cryptitis, crypt abscess, it's very subtle. It's very subtle. And also the inflammation often goes deep, go to submucosa. When you see these morphologies, alert yourself, possible this sexually transmitted infection. So go to the last part of my talk. So I showed you the histiocytic, lymphoplasmacytic, eosinophilic, and the minimal changes. This one, you can see the other pathology changes can suggest infection. Now, this is a 37-year-old man with history of HIV/AIDS, and then complained abdominal pain and diarrhea. So the entire colon endoscopically was normal, except the small polyp, 3 millimeter polyp in the left colon. And then they did this polypectomy. You can see lower power. The mucosa surface, totally normal, right? Essentially normal mucosa, but some mucosa, you do see a well circumscribed the nodule. And if you go to higher power, you can see the nodule is composed of spindle cells. The spindle cells, they are very bland. And then you can see some lymphocytic infiltration. Now, what's the differential diagnosis? We do see a mass lesion here. It's a lesion. We cannot let it go, right? The main differentials here, you can see maybe inflammatory myofibroblast tumor. Since the patient with HIV, we know patient can have mycobacterial spindle cell pseudotumor, can be carpooid sarcoma, can be inflammatory stool tumor, also called this follicular dendritic cell sarcoma, also can be other smooth muscle tumors, right? For these ones, we can do markers one by one to exclude, right? For example, if we do stains, OC is negative, but you can essentially rule out, the possibility of inflammatory myofibroblast tumor, but it's not complete because not 100% they have OC mutation, right? CD21 negative exclude possibility of follicular dendritic cell sarcoma, and HHV8 negative exclude for carpooid sarcoma, and the AFB negative exclude the possibility for mycobacterial spindle cell pseudotumor. And the leftover will be spindle cell tumor or others. Fortunately, we did smooth muscle actin and desmin. You can see they're beautifully positive. At that situation, one diagnosis, one entity came to my mind. Is this possible called EBV positive smooth muscle tumor? That's why I ordered EBV. You can see the EBV EBR beautifully stained all these tumor cells. And then this is EBV positive smooth muscle tumor. Right, the diagnosis is correct, I think. And then we went back to review the AFB stain because we thought maybe this is a mycobacterial spindle cell pseudotumor. But tumor cells stained totally negative. But when I look at the lamina propria, everybody can recognize them. You can see these histiocytes contain of this delicate filamentous material, this MAI infection. So the mucosa totally normal, endoscopically normal, microscopically normal, but we do see these ones. So I retrospectively reviewed H&E again. I do see the clusters of histiocytes. If I did not do AFB stain, I will miss this mycobacterial infection. So now the diagnosis is EBV positive smooth muscle cell tumor with concurrent MAI infection. So this, for the EBV positive smooth muscle cell tumor, occurs in the immunosuppressed status, just like other infections, most commonly seen in organ transplant or HIV patient. I know this tumor's morphology is different from regular smooth muscle tumor, but you keep that in mind. When you see this morphology, HIV patient, think about this tumor. And then sometimes HIV patient, you may see multiple tumors in the body, in the brain, in the spinal cord, in the adrenal gland, in the lung. They are not metastases. They are just multiple primaries. So generally, they are benign, indolent process, but sometimes they can have malignant transformation, can become to lemon sarcoma. And sometimes the patient may die from the disease. For example, this study, 4 of the 51 cases, they died from the disease. So this is another case to show you the dual infection. For example, this gastric biopsy. We do see dense lymphoplasmacytic infiltration, really like H. pylori infection. Actually, the stain shows up, that's really H. pylori gastritis. But if you go to higher power, you can recognize, I showed you before something, you can see some spindle cells, some hemorrhagic changes, more dense, and then dilated small vessels. Possible this carpooid sarcoma, HHV8 positive. So this patient with both carpooid sarcoma and H. pylori gastritis in the stomach. Last but not the least, you can see there's a 41-year-old male with abdominal pain get gastric biopsy. You can see the stomach is very, very inflamed. And then also the inflammation go deep, go to some mucosa. First, it is not lymphoma. I can't tell you. They're not lymphoma. Possible there's severe H. pylori gastritis, and we do H. pylori stain. The stain came back, H. pylori positive, but the inflammation is so severe, something may happen. And then we added one syphilis stain. You can see the patient with both H. pylori gastritis and the syphilis in the stomach. So in summary of our talk today, a significant number of GI infections. They show near normal histology or minimal pathological changes. They can show only subtle morphology changes, can suggest you think about the GI infection. And some infections can be dual, can be triple sometimes. And as a pathologist, we need to recognize all these patterns and correlate with endoscopy findings, clinical endoscopy findings, and clinical tests, and to help us to narrow down for the differential diagnosis. And we pathologists play important role in recognizing and diagnosing all these GI infections, and we participate in the treatment of the clinical team for this patient. Yeah, thank you for your attention. Now we are open for questions, if you have. Yeah.
It's not related per se. On the app, I'm looking at the submitted attachments, and I only have 28 of the slides.
So
Am I supposed to have all 173?
you are better than mine. I only have 14.
It's 14.
Yeah, yeah. I think they have some technical issue. They should put it entirely to be there.
Okay.
Yeah, we submitted the handout 2 months ago. They should be there. Yeah, I will tell them, let them know to add the full PPT over there. Okay, if you have no questions, thank you again for attending our session. Wish you enjoy Las Vegas. Okay.